Hi class, we're going to dive into chapter 5, the skeletal system, with this little lecture. And I'm going to warn you that pretty much from here on, the content is really intense. And there's a lot. If you were overwhelmed in chapter 4 and chapter 3, hold on to your seat, because from here on it really steps up even more so than it has been. Chapter 4 was kind of a little lull. It's a little bit easier of a chapter. Chapter 5, this chapter on the skeletal system is a lot. But the good thing is you spend a lot of time in lab working on this information. So some of the stuff that we'll cover in lecture will kind of zip through it, or some of the stuff that you cover in lab will kind of zip through in lecture. So let's talk in general about the skeletal system. Obviously, there's over 200 bones that you have in your body. You're not going to have to know all of them for this class, so that's a good thing. But this is also including, or in addition to, all the cartilage, all the ligaments, all the connective tissue. It's all part of the skeletal system. You have the axial skeleton, which is our main axis. That's our head and our trunk. And then our appendicular skeleton, which is our arms and legs. Or, as your textbook likes to say, the pelvic and pubic, or pectoral and pelvic girdles. So there they all are. Our axial bones, there's 80 of them, appendicular 126. And let's talk about some function. Obviously, support and protection. Those are the two big ones that students realize, but did you also know that they're for the storage of minerals? Did you also know that's where blood cells are produced? And obviously, movement as well. So each bone is a little bit different in structure, so it's going to be a little bit different in function. We're going to start taking a look at what makes all these bones different. So in terms of mineral support and storage, the skeletal system stores our minerals, main minerals being...
I ate all this.
Thank you, sweetie. She ate all of it. Sorry. I use movies to babysit my children so that I can lecture to you. Sorry about that. So let's talk about minerals. The main minerals being calcium and phosphate. So the most abundant mineral on our body is calcium, and our bones have the majority of that. 98% is in our bones. So let's talk about protection. That's an obvious one, right? Our ribs protect our lungs and our heart. Our skull protects our brain. Our vertebrae protect our spinal cord. And the pelvis is there to protect our reproductive organs. There's also blood cells that are produced in the red bone marrow within all of our long bones. And obviously movement. Our bones, in conjunction with our muscular system, work to provide movement so we can do silly things, right? And even allow for little dainty manipulations with our fingers. So lots of changes in body position, all that with movement. Let's talk about how bones are classified. 4 main ways. They can be flat, they can be long, they can be irregular, or they can be short. Irregular is kind of like the catch-all. It's like, it's not flat, long, or short. No, we'll just call it irregular. So let's talk about flat bones. They're thin, they have nearly parallel surfaces. This is our skull bones, our sternum, our ribs, our scapula. These are all very, very flat looking, and they have an extensive surface area so that muscles can attach to them for movement. Long bones are what you're probably thinking of when you think of your arms and your legs. They're very long, slender. The femur is the longest, heaviest bone in our entire body. Irregular bones have complex shapes. These are like our spinal vertebrae, the bones of our pelvis. Some of our skull bones are included in that as well. Short bones are like the bones of our wrist and the bones of our ankles. They're a little boxy shaped. And here you can see the general shape of some of these bones. Flat bones, long bones, irregular, and short. Let's talk about surface markings. The majority of this you're going to learn in lab, so I'm going to skip through it, but all of these surface features are there primarily for muscle attachment or for blood vessels to go in and out of a certain structure moving through the bone. So there's something called a head, a diaphysis, a neck. The diaphysis is the long part of a long bone. The head is usually like a circular part of a long bone. And some of these terms are only specific to certain types of bones. Like these are usually terms that are used to describe long bones. Process, tubercle, tuberosity, trochlea, condyle, these are all elevations or projections that are on all of our bones and different varieties: trochanter, facet, crest, line, spine, ramus. Again, it's not important that you learn these words. It's important that you know the parts on the bones in lab. In lecture, am I going to test you on these things isolated by themselves? Am I going to ask you, what is a trochanter? No, I will not do that. But I may ask you, which of the following bones has a trochanter or has a greater trochanter? And I would give you a list of bones, so you'd have to identify it that way. Hope that makes sense to you. If not, just let me know. Same thing with these words: canal, meatus, sinus, foramen, fissure, sulcus, fossa. These are all bone features that you do not have to know in isolation. You have to know them on the actual bones. So I might ask you, which of the following would you find a foramen? And I'd give you a couple bones, and then you'd have to list one that has a small opening or passageway on it. Here are some of the bones of our skull, the surface features of our skull. You have different canals and meatus in the back of our orbitals, a process called the zygomatic process making up our cheekbone. You have sinuses, or these empty cavities in the frontal bone. Foramina are these little holes. You have them in your chin as well to let nerves through. A long bone like the humerus. You have a head, you have tubercles, a little sulcus is like a little groove, a tuberosity is a raised part, the diaphysis is the long part, and then you have some trochanters and condyles on the distal end of the humerus. Same thing with the femur, some markings there, pelvis, some markings there. So there's some review questions, and just like the last lecture, you can pause the video, answer the questions, or you can answer these questions when you're doing the reading guide. So typical long bone has an epiphysis and a diaphysis, and then there's some articular cartilage in between, and that's sometimes called where our bones articulate together to form the joint. There's also a marrow cavity in the long bone. It's yellow bone marrow as well as red bone marrow. Red bone marrow is where the red blood cells are produced. The yellow bone marrow is actually fat storage. Did you know that fat is stored in your bones? Yep. So there you can see a cross section with the marrow cavity. Long bone has that compact bone and spongy bone in it as well. We'll learn all about that in a few minutes. So let's talk about the components of a long bone here. The epiphysis is mostly composed of that spongy bone, and there's kind of like a lattice work that forms that structure, and the spongy bone is then covered by the compact bone. So the spongy bone is deep, compact bone is more superficial. All of it's covered in a periosteum. A periosteum is like a little bone blanket, wraps around the outside of your long bones, and it's basically a connective tissue to protect and isolate that bone from all the other structures of the body. There's also arteries and veins that are innervating that area as well. So here you see there's usually like a nutrient artery or nutrient vein foramen that allows the arteries and veins to come into the bone, and this is supplying all the bone cells with all the nutrients that they need, taking away waste products, etc. And let's talk about collagen and phosphate. Bones are made of two main ingredients, collagen and calcium. So the collagen is 1/3 of the weight of a bone. It's this strong and flexible. This allows our bones to bend a little bit. And then the calcified matrix, which is made of mostly calcium. It's calcium crystals. They're hard and flexible, very, very brittle. So the combination of the hard, inflexible calcium and then the flexible collagen is what makes our bones so dynamic. There you can see a bone without a calcified matrix is really bendy. Here's a little review. You can pause the video, answer the questions, or answer them in your reading guide. Let's talk about bone cells. Bones are made of cells, believe it or not. There's three main types of cells. There's osteocytes, osteoblasts, and osteoclasts. So let's learn the difference. Osteocytes are mature bone cells. These are the ones that are being bones. They're just in the bone. They are surrounded by a little calcified matrix. They live in a little nest called a lacuna, and they're connected to other bone cells by little canals called canaliculi. They play a role in bone repair, but they themselves cannot divide. They're kind of just old grumpy cells that live by themselves. Osteoblasts are the cells that are producing new bone. They're constantly being regenerated, they're producing new bone matrix, and they are involved in this process called ossification. So they're very active while you're growing. They make and release proteins like the collagen protein that helps our bones stay flexible. Osteocytes will eventually develop from osteoblasts. So basically, osteoblasts are the workers, and then once they're old and tired and grumpy, they become osteocytes. Hope that makes sense. Then you have osteoclasts. Osteoclasts are big cells. They come from the same stem cells that made up the other cells, but these guys do the opposite of osteoblasts. Osteoblasts are building. Osteoclasts are breaking. These guys are going through and dissolving bone matrix. So you might think, well, why would we want the bones to dissolve? Is that a bad thing? Well, not always, because when the bones are growing, as they get bigger and bigger, that medullary cavity needs to get bigger also. So the osteoclasts are in there making room for new blood to be made, making room for new marrow. It's called the process of osteolysis. So here you can see some of these terms I was talking about. You see an osteocyte. It's living in its little lacuna, its little nest here. The osteocytes is this little thing, the black thing, and then the pink stuff is the lacuna, connected by canaliculi to other lacuna. An osteoclast would live on like the inside part of a bone. See right here, the inside part where the nutrient artery and nutrient veins are. So this is a huge cell, lots and lots of nutrients there, dissolving away this inner part of the bone marrow. And again, it's just a big cross-section of the entire bone structure. All of these cells create what's called an osteon. An osteon, or a Haversian system, or Haversian canal, it's sometimes called, is the basic unit of compact bones. So there's a central canal where there's arteries and veins, and then there's those concentric rings. You can see these Haversian systems. I just backed up a little bit. Right here. This is a osteon. This is an osteon. This is an osteon. All of these little tree trunk-like structures are osteons or Haversian systems where there's a central canal with the artery and vein, and then branching out from that artery or vein are little tiny canaliculi serving for communication between the cells. So there's a real picture of an osteon. Let's talk about calcium balance. Calcium ion concentration has to be carefully balanced in our blood. It cannot fluctuate more than 10% in either direction. So that means our body has to carefully monitor and control our calcium absorption and calcium excretion. So our skeleton, our bones, are constantly eroding and depositing new calcium based on our dietary needs. Guess what? If you're not eating lots of calcium, what are your osteoclasts doing? They're breaking up your bones to put calcium back into the blood because other cells need calcium too. But guess what? If you have a diet that's high in calcium, your bones can stay nice and strong and they don't have to dissolve to give calcium to the blood. So osteoclasts are going to release calcium into the blood. Osteoblasts are going to take calcium from the blood and deposit it into the bones so our bones can be nice and strong. The intestines serve a role in absorbing the calcium from our diet, and our kidneys can help get rid of extra calcium if we have excess. So all of these organs are involved in calcium balance. So here's a little review for you of this little section. You can pause it and answer, or you can answer the questions in your reading guide. Let's talk about the difference between compact and spongy bone. Compact bone is made of those osteons that we just talked about with that central canal. Spongy bone does not look like that. Spongy bone does not look like a tree trunk. It looks more like I don't even know, like stalactites and stalagmites. They're called trabeculae. There's no capillaries, there's no venules, and it's very light because there's lots of airy space. So here you see the spongy bone that's then surrounded by our compact bone. Compact bone is made of those osteons, and our trabeculae is not. Our trabeculae is made of the calcium and the collagen. So our bones grow in a couple different ways. One is called appositional growth. Appositional growth is where the bone is enlarging in diameter. It's just getting wider. It occurs at the surface. It's growing on the outer surface and just getting bigger and bigger and bigger. Bone matrix is added to that surface. The osteoblasts are differentiating into osteocytes and laying down new calcium and just continuing to grow and grow and grow. This is a picture showing you that appositional growth. You don't have any here, and now all of a sudden, appositional growth. happens right underneath of the periosteum, that little blanket. The endosteum is that incomplete cell layer that's in our bone marrow. This is where bone growth can occur also. This is also where bone repair occurs. It's basically covering the trabeculae, lining that inner surface and any exposed surfaces. So the endosteum is this inner lining. It's incomplete, meaning, see how it's kind of broken here by this osteoclast? It doesn't cover the entire inside, but it covers the majority of the inside. And it's a huge germinative layer where new bone cells can be created if they need to be, if the bone has been broken or compromised. So here's our quick review. You can pause the video and answer, or answer on the reading guide, as always. We also have endochondral ossification. This is the most common form of bone formation. This is when a bone is basically modeled after a cartilage scaffold. So cartilage will be laid down first, and then that cartilage will begin the process of ossification and become a bony tissue. So the first part is that cartilage begins to enlarge and the chondrocytes enlarge, and there's a kind of cavity that is formed. And then blood vessels can come into the area because cartilage is not vascular, right? There's no blood vessels going to cartilage, only to bones. So the blood vessels start to come in, and then the blood vessels can start to form a central canal region, forming what's called an ossification center. And this ossification center is where all these new cells get their juices, so to speak, so they can divide and grow. And this growth continues along with the remodeling. So that marrow cavity is basically created, that tissue can continue to expand and replace the cartilage. Capillaries and other osteoblasts can migrate to the ends or the epiphyses, and then those epiphyses are filled with spongy bone. So you have this whole piece of cartilage, and it begins to become vascularized, lots of nutrients coming to the area, and then ossification can occur. That calcification and ossification are two different things. Calcification is when you're laying down the calcium. Ossification is when it's turning into bone. And so that's what's happening here. It's calcifying and ossifying, and that cavity enlarges, and new little growth centers occur on the epiphyses, and then before you know it, bing, bang, boom, you got a long bone. That happens mostly during embryonic development. There's also intramembranous ossification. There are a few bones that undergo this. This is where the stem cells will differentiate into the bone cells after, or rather not from a cartilage frame. So this is going to occur in what we call membrane bones. Our jaw, our skull, our patella, our kneecap are all examples of intramembranous ossification. The bones grow from the membranes that are within those areas of our body. And it basically just occurs in the same way, but without a cartilage scaffold. Here you can actually see 16-week-old fetus with ossification going on. These bones are forming through endochondral ossification and intramembranous ossification. The epiphyseal line is that line in between the epiphysis and the diaphysis. This is the growth plate. This is where the growth is going to occur on a long bone. It's going to continue to elongate at that point under the direction of sex hormones, growth hormones, and thyroid hormones, which all play a role in metabolism and growth. Those osteoblasts are working really hard in that area to enlarge the bones. Little section review for you. Let's talk about atypical growth. You have pituitary growth failure. This is from inadequate hormone production from the pituitary. Your epiphyseal line or epiphyseal cartilage will not grow, and therefore your bones will not get longer. You'll have abnormally short bones. It's fairly rare, but children that do have it can be treated with a synthetic growth hormone. There's also achondroplasia, which is a genetic disorder resulting in short, stocky limbs, but a normal trunk size. And here you have pituitary growth failure versus achondroplasia. Marfan syndrome is another inherited condition. This is where you have excessive cartilage formation. So you have very, very long bones. It also affects, what is it? The C one. Collagen, sorry. It also affects collagen. So you'll be very flexible, be able to bend and move in different ways that other people can't. That's Marfan syndrome. Very long, people with very long arms, very long legs, usually have a very long face as well. Could have Marfan syndrome. You could live a totally normal life and never know it. Typically, people with Marfan syndrome also have heart issues as well, though. So eventually, you'll probably find out. Gigantism is the overproduction of growth hormone before puberty, so you get very, very tall. Puberty is usually delayed in these individuals. And then acromegaly, which is where the growth hormone continues to be released even after the growth plates have sealed, so your bones get very thick. So this would be very strong jaw, big hands, and etc. So this is gigantism, just very, very long bones, very tall. Versus acromegaly, which this individual has, again, very strong, pronounced jaw bones, thick, heavy bones there. There's also heterotopic or ectopic bones. These are abnormal conditions where the stem cells will develop into osteoblasts. So there's diseases, it's a single gene mutation called FOP, fibrodysplasia ossificans progressiva. It's basically causing the deposition of bones around our muscles. There's no treatment, but it's very sad disease because these individuals end up growing bone tissue all over their body, makes it very difficult to move. You can see, for instance, the skeleton of somebody who has this condition. Think about how painful and awkward it would be to move. Very, very sad. Here's your review. You can pause it and answer, or answer when you read the reading guide. Let's talk about bone fracture and repair. There's several processes that take place when you're repairing a bone. First is a large blood clot called a fracture hematoma. This happens within several hours of the injury. Then there's an internal callus and an external callus that form. These are just kind of overgrowths of cartilage or spongy bone to help stabilize as much as possible. Then there's that cartilage callus is slowly replaced by bones, and then finally bone remodeling, which is a combination of osteoblast and osteoclast activity, occurs to reshape the bone back into its position. So let's say you crack your humerus in half, you have this fracture hematoma, your calluses form, internal callus, external callus, and this is over several days or weeks, again, depending on if you had surgery. If you have surgery like the next day to, put a plate in there, all this is much more accelerated. But if you just, let it hang out and you don't get surgery to fix it, it will take much longer. And these calluses will slowly ossify and grow together and will form a bump. I broke my wrists last year and I still have a bump in my radius. And it was funny because when I broke it, it wasn't funny when I broke it, but when I did break it, I said, "Oh, my distal radius!" Like what a nerd that I like yelled, "Oh, my distal radius," when I broke my arm, but I did. I also broke my shoulder last year, and interestingly enough, I broke it right here. I just snapped the head of my humerus off. Isn't that awesome? No, I don't have a bone disorder. No, it did not happen at the same time. I just had really bad luck. Anyways, back on topic. Let's talk about the types of fractures. They can be closed or simple. They can be open or compound. This is when the bone's sticking through your skin. Ugh, that's a nasty one. Transverse, spiral, displaced, compression, or green stick. These are all just different types of fractures. Comminuted, epiphyseal, a Pott's fracture or Cole's fracture. These are fractures that are pertaining to specific areas of the body. And here you can see the associated images with those types of fractures. And our review questions are right here. Let's go through the skeleton. Now, for this part, since you're going to be learning these bones in lab, I'm not going to take time to go through every single one of them, but I will say that you do need to know the bones that are covered in this PowerPoint, and they may appear on a test or on your quiz. And I would ask the questions something like, which of the following bones is not associated with the cranium? Which of the following bones is not in the upper arm? Of these bones, which one has a trochanter on it. So I would be asking you questions like that. I'm not going to give you a diagram. I'm not going to have you label anything on any test or quiz, just so you know, any of my stuff. Your lab instructor may have you do that, but for my part of the class, you will not have to do that. So let's just flip through these bones real quick. Facial bones ultimately are there for our muscles, for our jaw muscles, as well as facial expressions. And they're listed here: nasal, lacrimal, palatine on the back of our roof of our mouth there, and the bottom of our eye socket. Zygomatic are cheekbones. Maxillae are the top teeth. Inferior nasal conchas on the inside of our nose. Our vomer is in the inside of our nose too, and then the mandible is our lower jaw. All of our cranial bones form our cranium, which protect our bone. You have the frontal bone, the sphenoid bone, which is a weird little bone that's inside. The ethmoid bone is another one. You can see a little bit through the eye socket, but not a whole lot there. The zygomatic bones I mentioned before. The parietal bones are on the side. The temporal bones are at your temple. The maxillae I already mentioned. The nasal bones are at your nose. You can see a little bit of that weird ethmoid bone back there sticking down through the skull. You'll see these on the models in lab as well. Occipital bones on the back of the head. And we have sutures joining all of our skull bones together, like a coronal suture, which is separating the frontal bone from the parietal bones, the sagittal suture between the two parietal bones, the squamous suture, the lambdoid suture, all between the various skull bones. There are the sutures. Here's our review. You can pause and answer the questions while you do the reading guide, either way. Let's go to some surface features. I'm just going to zip through these. Do you have to know all of these? Absolutely not. Your lab instructor will tell you what you need to know from this list for your lab. I will not be asking you questions about these on your test or quiz. So I'm flipping through them, although these pictures may help you on your lab material. Again, I'm continuing to flip through these because you don't need to know those for my part of the class. You may need to know them for lab. That's up to your lab instructor. Same thing with these structures on the inside of the skull. Sorry, my eye's itching. You do not need to know these for me, but you may need to know these for your lab instructor. The sinuses here, again, depending on your lab instructor. Some other bones of the skull, the hyoid bone, you should know what that is for me. That's an interesting bone. The auditory ossicles, you'll probably get to know those later when we do our senses. And same thing with fontanelles. You do not need to know these for my part of the class, but you may need to know them for lab. Our vertebral column, just know some statistics like this. How many are there? What types are there? And what's their functions? For instance, we have 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar, 5 sacral, and about 4 coccygeal. 7, 12, 5, 5, 4, as I always like to say. 7, 12, 5, 5, 4. That's 7 cervical, 12 thoracic. The thoracic vertebrae are associated with the ribs. The lumbars are lower back. The sacral vertebrae are in between our pelvic bones, and the coccygeals are little tail. The cervical are our neck bones. This goes through and shows you the different structures of our vertebral bones and how they differ between vertebrae. You do not need to know that for me, but you may need to know that for your lab instructor. So I'm zipping through this because, again, you don't need to know it for me, but you may need to know it for your lab instructor. All of the facets, the foramen, again, that's up to your lab instructor. You should know these two. These two are the most important vertebrae. It's the first 2 vertebrae that are just below your skull, at the very top of your spinal cord, the atlas and the axis. You should be familiar with them and what they do. It's on your list of possible essays for this exam. You may be asked about this on your test. That's a hint. There you see them articulating together. Here are the thoracic vertebrae. Again, you should be familiar with what makes it a thoracic vertebrae, but you don't have to know all of the specific parts to it. Same thing with lumbar vertebrae. What makes a lumbar vertebrae different from a thoracic and cervical vertebrae in general? It's bigger, it's thicker, right? But you don't have to know it has a triangular vertebral foramen or it has a slender transverse process. You don't need to know that for this class. The sacrum, Again, you don't need to know all of these terms for my purpose, but you may need to know them for your lab purposes. The thoracic cage, or our rib cage, is our bony support, right? It expands when breathing and helps to maintain our vertebral position, helps to hold our pectoral girdle into place. There are 3 different types of ribs: true ribs, false ribs, floating ribs. You should know the difference between those. And our sternum is where some of those attach. And kyphosis is that kind of rounded humpback appearance that some people get as they age. It's also a chronic condition. Usually it's a musculoskeletal issue or due to abnormal vertebral growth. Scoliosis is when you have a lateral curve of your spine. So instead of hunching forward, kind of have an S curve to your back. Lordosis is swayback. This happens in overweight individuals or pregnant ladies when you're carrying all that weight on the front. You can see this is a very exaggerated lumbar curvature that she has because she's carrying all that extra weight on the front, although she's not that big for a pregnant lady. Pectoral girdle. You should be familiar with what the pectoral girdle is. This is our clavicle. This is our scapula. This is holding our arms onto our body. There's lots of bones and connections, ligaments there. You should be familiar with how the arm is held onto our body. You don't have to know the parts of the scapula, but you should know what a scapula is. And again, same thing. You should know what a humerus is, but do you have to know all these parts of a humerus? Absolutely not. You may have to know them for lab. Pelvic girdle, again, you need to know what it is, but you do not need to know all of the details that are mentioned in your book. You may have to know them for lab. You do have to know the 3 hip bones, or the 3 pubic bones, the ilium, the ischium, the pubis, how they fit together to create the coxal bone, what the pubic symphysis is, but you don't have to know all of these little bone landmarks. For my part, you may need to know it for lab. The sacroiliac joint is where your sacrum and ilium come together, excuse me, at the back. And moving beyond false pelvis and true pelvis, you should know the difference between a male and female pelvis. Females obviously have a wider pelvis for childbearing, broader angle, less curvature to the sacrum and coccyx, so it doesn't curve inward, it stays outward. Men have more of an inward curve to the sacrum and coccyx, a very low pelvis and wider iliac flare. So you can see the difference here. This is much bigger and wider. Males look more upright. Again, this would be curving inward. This one curves outward. Look at the size of this pubic outlet here, much bigger than here, which is considerably smaller. So moving on to the lower body, again, you need to know the bones, but do you need to know all of the specific parts? No. Should you be familiar with the fact that the femur has a head, a neck, a trochanter? Yes. But do you have to know all the names? No. So here are the parts of the distal end of the femur. Again, it has condyles, it has a patellar surface. I'm not going to give you a diagram asking you to label anything. The tibia and fibula, one of my biggest pet peeves in the world is calling it a tibula or calling it a fibia. Just know what they are. It's a tibia and a fibula. The words really don't sound alike. They both have the letter B in them, but otherwise they're completely different words. So you should not be mixing them up as long as you're paying attention when you are reading and writing. These are the landmarks. Again, you don't need to know them for me, but you may need to know them for lab. And same thing with ankle and foot. You should know tarsal, metatarsal, and phalanges. You don't have to know the specific tarsals or metatarsals. You do not have to know about the arch of the foot either. And this is a condition called clubfoot, congenital talipes equinovarus. It's basically when the arch of the foot does not develop properly, and so the muscle growth kind of distorts the bones a little bit. This could be in one foot or in both feet, and usually a cast or some type of splint device will correct the clubfoot condition. Let's move on to joints and movement. Where two bones come together, where they interconnect, is a joint. Some of our joints are immovable, like the joints in our skull, right? You have the parietal bones coming together, frontal and parietal bones coming together, those sutures, there's no movement there. It's called a synarthrosis. And amphiarthrosis is little movement. This would be like between our sternum and our rib cage. As our thoracic cavity expands and contracts, you have a little bit of movement there between the sternum and the rib cage. That's an amphiarthrosis. A diarthrosis is all this, right? This is our big movers, freely movable. So, oops, I skipped some. So our synarthrosis would be sutures, like I mentioned, kyphosis, our teeth, and a synchondrosis, which is that cartilaginous connection between two bones, like the epiphyseal plate, so to on our long bones. An amphiarthrosis is stronger than a freely movable joint, and it has just a little bit more movement involved in it. This is like our hip bones, like our pubic symphysis. And then the diarthroses are our synovial joints. These are freely movable. And as with on our body, as the degree of movement increases, stability decreases. So something like the shoulder, which is our most movable joint, we can move it around, we can move it over, we can move it up and down, right, in all these different directions. It's actually our least stable joint. Whereas something like, our fingers, which are just typical hinge joints, those are pretty stable joints in terms of, healing processes and the ligaments that hold everything together. So let's talk about all of the parts of a synovial joint. Again, they allow for free movement. There's articular cartilages at the end of the long bones. There's a joint capsule that's filled with fluid. There could be tendons and ligaments associated with that. That fluid is called synovial fluid, and it's there to lubricate, cushion, and protect. Here you see a typical synovial joint with the articular cartilage. You see the joint capsule, which is just a little membrane surrounding it. And there may or may not be ligaments and other supportive structures in that cavity. Overall function of synovial fluid: lubrication, to help kind of grease up the gears, so to speak. It also helps to distribute the nutrients to the bones. And it's there for shock absorption, right? Because these movable parts are not as stable as the immovable parts. So we have to be able to absorb some shock there. Some structures associated with the knee joint, you should be somewhat familiar with these. Think something like a bursa, fat pads, meniscus, and there's other ligaments in there. The bursa are little fluid-filled pockets that help reduce friction between the ligaments and tendons in there. And then there's some fatty pads that are in there for insulation and protection. A meniscus allows your knee to kind of bend and move in different ways without grinding onto the articulating bones. And then the ligaments are there for support. Here you can see the overall anatomy of our knee. You have some fatty pads in there. The meniscus are these fibrocartilage pads, which are in between the articulating bones. The ligaments and tendons, which are holding it all together. There's lots associated with the knee because our knee is also very movable. So again, you can pause the movie or pause the video here, or answer these questions when you do the reading guide. Finally, synovial joints, some of the types of synovial joints. These are just examples of how they move. So all of our movable joints are classified into these categories. And this image here helps you understand how they work. Something like a gliding joint, where the surfaces are just gliding right near each other, or a hinge joint, where it's opening and closing like a door, or a pivot joint, like our atlas and axis connection, so on and so forth. Let's talk for a minute about intervertebral discs. They're basically the little pads of fibrocartilage that go in between the vertebrae. It's just a fibrous pad, and there's a little gel core in the middle of it. A bulging disc is when different stresses, like weight bearing, will force that disc into the vertebral canal, whereas a herniated disc is when you're actually going backwards and you're impacting the spinal nerves. So an example here, you have the bulging disc. It's just coming out laterally. It's painful, but not nearly as painful as this, where you have the herniation is basically a disc that's impinging upon a nerve that is sending or receiving information. So that could be very difficult to deal with. Osteoporosis occurs with normal aging. As we age, our bones become thinner and weaker. This all happens around age 30. Bone ossification and calcification begins to slow down dramatically. Osteoblast activity declines. Women are actually losing 8% of their skeletal mass after the age of 40. Men only lose 3%. It has to do with hormones like estrogen. Osteoporosis is the condition that's going to contribute most to fractures in the elderly. And here you see a bone with osteoporosis. That spongy bone is very, very weak and brittle, whereas when it's normal, it looks pretty strong. Here you can see a compressed spine, the lumbar vertebrae, and this can happen with the deterioration of the bones over time. Lots of impact sports like jet skiing or horseback riding, something where you're pounding a lot, motorcycle riding, even dirt biking, can cause lots of stress on your lower back. Arthritis is a condition that's affecting specifically our joints. There's rheumatism, which is just a general term for stiffness. This is something that affects all of us as we age. As you get older, it gets a little harder to get out of bed. You're a little more stiff in the morning than you used to be. Arthritis can be called osteoarthritis. It's depending on the cause. Osteoarthritis is just from wear and tear. This is going to happen if you overuse your joints. If you're a runner, you're probably going to get osteoarthritis in your knees eventually. If you're a swimmer, you might get it in your shoulders, right? Osteoarthritis is just from general wear and tear. So here you see normal cartilage. It's nice and smooth and healthy looking, whereas arthritic joint cartilage is tearing, ripping, and wearing away. An arthroscope is a small device that's used to examine these structures, and arthroscopic surgery is when they're actually putting a device into your body along with the medical instruments so they can see what they're doing as they're operating. Generally, the incisions are much smaller, so you can actually do arthroscopic knee surgery. Instead of having a big, huge cut down the front of your knee, you might have a couple little cuts because they put the camera in one, a light in one, and then some scissors or forceps or whatever in the other categories. Artificial joints are available and are a great alternative to living with pain and living with arthritis. You can get them for just about every synovial joint. I met someone the other day who just had her she had her knuckles done. I didn't even know that was a procedure, but she had her knuckles, they weren't replaced, but they were like shaved down and new cartilage was put in because she had such bad arthritis. Her hands were very crippled. Kind of cool. The downfall of artificial joints is they don't last very long. So someone who's young and healthy in their 20s or 30s, they tend not to give them artificial joints because the lifespan of these artificial joints is only 10 or 15 years. So you're going to have to need another replacement in your lifetime. And of course, joint replacement is a very stressful, difficult surgery. Artificial knees, artificial hips, artificial shoulders even, very complicated and have a very long healing time. Wow, we did it. That was all of Chapter 5. Please let me know what questions you have and continue to work hard in the class. Let me know if you have any questions. Bye.